Hello, my name is Dominique Allwood. I'm Director of Improvement and Partnerships and a consultant in public health medicine at UCL Partners. We're an organisation that brings together a number of academic and NHS organisations to improve health and care through working with organisations such as national clinical audits and through academia, through innovation, through education and evaluation. So bringing together a number of pieces of expertise into our portfolio. And I'm here today to talk about how you can use some of the data that's coming out of your audits and use QI methods to help implement improvement in your local areas. Now, many of you will be familiar with quality improvement and some of you less so. So I've tried to cater for a sort of range of backgrounds and experience here. So I'm going to just be talking about where improvement fits really within the kind of audit cycle. You're all familiar with that. We know the difference between audit and improvement is about audit is setting standards and then checking whether you meet those standards. But in order to make sure that you're meeting those standards, you may need to enact some changes or improvements. Really what I'm going to be talking about. So I'll just flash this model up very briefly. It's called the model for improvement. I'm not going to say too much about it here, but it's just to say that in that audit cycle, improvement comes in there to help make those changes. So I'm stealing a bit of data from Mark. He has some things from the NICOR audit, the NCAP audit, and one of the things that we've got here is the improvement in the proportion of patients referred to cardiac rehab following a myocardial infarction, so following heart attack. And what we can see is some really great data that shows trends over time. And what I'm most interested in is the bar chart at the bottom, which many of you will be familiar with. And although there's been some good improvements over time, not all hospitals are referring as many patients as they could be to cardiac rehabilitation. So if you look at the line in red, anyone below that is below the average. And so what we could say is if we were one of those hospitals, we might take this as an area to think about doing improvement. Now, audit data is great for a huge number of reasons, but I've put a sort of tin opener picture here because really I'm trying to show that it does open the lid to show you that there's more going on, but you're going to need to do some work as well to understand the data more and to bring in some improvement method to change. So that's what I'm going to talk about now, really. So the question we need to ask ourselves then is, how do we want to improve the proportion of patients referred to cardiac rehabilitation following an MI in our organisation? And there's a number of ways in which we can think about that. So I've just mentioned that audit data really helps you understand where your organisation stands relative to others. So it's really great for benchmarking. And you can then look at all of those organisations that sit near the top, and if you know who they are, you can approach them to understand what they do. What audit data is less good at telling you is within individual organisations yourselves, is your organisation providing equitable services across all of your patients? Do you know where the variation exists? So for some clinicians, they might be practicing in one way, and for others, they might be practicing in a different way, or that on certain days of the week, you might be getting a particular pattern of referral, etc. And do you know how you've improved over time? So that bar chart I just showed you provides a snapshot in time for that particular organisation. It doesn't show you whether that organisation was better or worse. The data above it showed that overall there was a change in how referrals were being managed post-MI, but not for this particular organisation. So data is really important for a range of things in here: benchmarking, equity, what needs to be improved, and taking action. So we'll talk a bit more about that in a moment. Data can be used to inform you in a number of ways. So it can help you to look at your current performance and provide you with that baseline. It can show you where your gaps are so that you can prioritise your improvement projects. And it really helps you set aims and targets for improvement because you can see where you are and where you want to get to. And it's really important for persuading and engaging others, particularly busy clinicians who have got a lot of other priorities. Why should they be spending time doing something improving the area that you've sort of helped to identify? So data is really important for many reasons, and I would urge you to be thinking about, once you've found an area in the audit, what data underpins that, where can you go and find out more, does that need to be data that you go and specially collect, or is that data that your organisation is already collecting? So we have this issue around referrals to cardiac rehab. So the first thing we want to do is develop an aim around our improvement project. And many of you will have heard about SMART aims. It's about being specific, measurable, attainable or achievable, relevant and time-based. And I'll show you what that means here. So we've got some examples of some slightly weaker aims versus some strong aims, and we'll take the top one because that's most relevant to me. So we could just say generally we want to increase the number of patients referred to rehab from our hospital. But the question would still be left as to, well, increase by how much? How are we going to measure that? How are we going to know that we've done that? And also timeliness, by when? So is that in the next 3 months, the next 5 years, over how long? And when are we going to look back and say we've either done it or we haven't? So we need to move the aim into a SMART aim, which would be to increase the number of patients referred to rehab, and here we've said 20% by December next year. You can see something similar for an aim below that doesn't start off as particularly smart. It's a great aim, but we need to add some more specificity to it. So that's often by adding percentages and places and dates, etc. So we've now got our aims. We've looked at the audit data. We've seen that there might be an issue for our hospital. We've understood the area of the problem, and we've decided that our aim is now to increase the number of patients referred by 20% next December. So how are we going to go about that? Well, we need to understand what the issues are driving that and where the ideas might come from. So as I said, you may look at your other colleagues and the national data to say, well, what's best practice? What are others doing? You may go out and walk the journey. You may go and observe what's going on. You could look at complaints to find out why people hadn't been achieving that level of service. You might go and meet with colleagues. You might look at patient experience data, and you've got a choice as to whether you look at things from a sort of top-down perspective. So there might be some national directives that say these are the areas you need to improve in overall, and this applies to everyone. Or you might do that bottom-up, understanding from your colleagues and your patients who are closest to the issues what is going to improve that referral rate. One of the QI tools that you can use, the quality improvement tools, is process mapping, and it helps you to represent visually the process of your journey in the area that you're interested in, and it helps you to do that in order to understand the ideas for change. And you can look at the current state and then decide where you might want to get to. And it's often quite nice to do this with all the stakeholders in your project, because they can help you kind of map that out much more accurately. So I've just got a very brief example of creating a process map for a patient who arrives at a GP practice, and this is about having some blood tests done and how they get the result back. And you can see actually it's not as simple as you might assume at first thought. There's a number of steps that go through the patient having to have that procedure done, then where the information goes, who makes the decision, etc. And if you start to map out your process, you can identify what's called sort of fail points or issues or wastes, where either people need to wait unnecessarily or there's likely to be a common problem that occurs in that area. And what all that does is generate areas for you to think about your improvements. If we go back to our referrals question, we would map the process out from potentially when the patient's had the MI all the way through to going home, and at what point you would expect somebody to be initiating that referral, and see what happens now and why that's not happening as planned. So the top tips for that section about sort of understanding your QI problem more are understand if you're going to process map, what's the start and end point. You wouldn't, for that referral piece, you wouldn't necessarily start all the way at the point of the patient having chest pain, because actually you may be interested in a later start point. Get people around the room together to collaborate on your process map, and start with what currently happens. So avoid people jumping into what's supposed to happen in principle or what the policy says, but really try and map what currently happens, so where things break down. And don't do the redesign at the moment, but park all those things that come up in the ideas. It's really important that you capture them, but at this point you're trying to do the diagnostic, what's the problem, before jumping to the solutions, because you might need more evidence and data. So really importantly, we've touched on it's good to have people around the table. Actually, for the overall QI project, it's really important to engage people and build a team. So just a few questions to help you think about that. Who might need to know about your work? So who is the people that are directly affected? That might be staff and patients, and which types are they? So don't just put staff in a big group, but what kind of staff and where do they work? And who are the patients that might be needing to be involved? Are those ones that have had a good outcome that can tell you more about that? Are those ones who haven't had such a good outcome? Think about the sponsors in your project, potential sponsors, if you don't have any at the moment, around who's going to really help make your project be supported and influence the outcome, and who might stop and stall that. It might be people directly involved in the pathway, but it could be more wider stakeholders. And particularly important, how are you going to involve patients and the carers in any redesign or improvement that you do, because it's really important to have them involved. And there are many different mechanisms that your organisation will have to help you do that. That might include going to gather experience and insights, involving them in process mapping, asking what they think they could be done better, and also having them involved in the co-design of the improvements. Another really key message is about using data to drive improvement. And I talked about data a bit earlier on, but I just want to come back to it. And I'm going to use this model that I also referred to. So this is known as the model for improvement. It's got 3 questions. First one is, what are we trying to accomplish? We've almost covered that off in a way through our SMART aim. The second one is, how will we know that change is an improvement? And we're just about to talk about that now. So what data is going to tell us that if we do something differently, that we've actually made a difference and it's got better? And the third question is, what changes can we make that will result in an improvement? So that's the sort of ideas generation, and we've already touched on that a bit through the process mapping. So, and then it goes into how do we go and enact that change? So let's just stick with question 2 now. After we've got our aim, how are we going to measure it? And this is really important to have data. So without data, it's really difficult to know what we're doing. It helps us understand our problems and issues. It helps us gather baseline data, and it helps us check if our interventions are working and communicate that effectively. And I mentioned before that often we find there's issues around clinical engagement, and that's for a whole number of reasons, but some of that is often just being really busy and lots of competing priorities. So data is a really powerful tool, particularly if those people you're trying to influence have been involved in the data collection, so that they don't necessarily criticise the data for being incomplete or poor quality. So I'm just going to show a couple of examples of how we represent data in our improvement work, and what this is called a run chart. So that means that you see a run or a series of points over time, and you have time on the x-axis and any indicator to be measured on the y-axis. So here we might have percentage of patients that were actually referred to the rehab after having an MI, and we might look at that by week or by month, and we'll see that going up and down with variation. It's really important to think about data over time, because actually it's quite misleading to look at 2 time points or bar charts. We often love bar charts because they're often very simple ways of showing pieces of data, but they're pretty bad for improvement. So if you look at the bar chart at the top, we can imagine that somebody's tried to make some changes, and before they made the change, they had a certain measurement, and then after it had gone down. So that on the face of it looks like there's been an improvement. And if you looked at the little chart below, you might collect a series of points and take that average and say, okay, it was a bit higher before and it's gone down. But actually there could be a whole lot of other things going on in that data. And really what those small graphs show at the other side is just different examples of what may be going on. And in reality, most of those show that there hasn't actually been a significant improvement after you've made the change. It just happens that you've picked 2 data points that are really different from each other. So the message here really is to make sure that you look at data over time. And I mentioned this word variation. There are actually a different version of a run chart called a statistical process control chart, SPC, which starts to put limits, lines on your run chart to help you see whether you're going outside of what you would normally expect, normal variation. So I'm not going to talk about that here, but I think it's really important if you're interested in looking at data, how things are changing over time, and whether you're making a real difference, that you look at run charts at a baseline, but also that you start thinking about SPC. And here's just an example from one of your audits about why it's really important to look at data over time. And you can also annotate to say, well, we made the change here, and then have a look to see whether there was an improvement. And you can start to interrogate that a bit more. So this section was just about the data. What makes data really effective? Well, it's about making sure that you've got baseline performance to compare to, that data is provided by colleagues, that you can see it over time and it's continuous, and there's lots of different formats, but that you really set targets and action plans and you use that to measure change. So you can use your audit data as a way of starting to look at that, but you may well need to go into more local data sets to understand how things are evolving. So we're into the third question now for this model for improvement, which is really about what are the ideas that are going to get us there. So you remember we talked about what's our aim, and we've looked at the SMART aim. What are the changes? How are we going to know that the changes have made a difference? That's our measurement. And this third section is what are the changes that we could do? And we can use a QI tool called a driver diagram here, which basically sets out a plan on a page of what you're aiming to do and how you're going to get there. And it starts to prevent a bit of what I call magical thinking, where you have a whole load of ideas that people have generated and an aim over here, and maybe the two don't necessarily link up. So how do you know that the ideas you're suggesting might well drive that aim? And in a way, it's a bit of a hypothesis or prediction. So you have your aim, then you pick some primary drivers that are the things that will definitely, or you hope will lead to having some impact on your aim. You might have another layer of things that will impact that called secondary drivers, and then you have change ideas to test. And I'll show you that in more of a visual format. So this is a driver diagram here, and you kind of read it from right to left or left to right, depending on which way you look at this page. But you start with your aim, and in order to achieve the aim, these are the primary things that we think will do that, which require secondary drivers, which require things to be changed. And I'll show you a couple of real life examples. We've got quite a simple one here, which is to reduce secondary heart attacks by 50% within 18 months. Now, I'm slightly being a bit facetious where I say simple, because actually that's a huge aim. But what we've managed to do is boil it down to a small number of things that we think we could go and tackle, because that's absolutely massive. So the people that have designed this driver diagram think that having engagement, communication, and tackling patient experience will be the things that lead to improving this aim. So improving engagement, improving communication, and patient experience. And then within that, they've come up with some secondary drivers, which are about working with communities, giving training, understanding continuity of care, making sure patients have an echo before they're discharged, and making sure that patients get the care that they're supposed to at the right time. And then they've come up with a number of change ideas around referrals, around the type of ward, around drugs, etc. So you'll have many more and better examples, but this was just one to say you've got an aim over here and you've got a whole load of activities, but how are they going to get you to that aim? So people could have just chucked into the pile drugs and referrals, etc., but how are they going to lead to reducing this this aim here? So I guess my urge would be to you, have a go at driver diagrams, stick your aim on one side, have a go at some of these. It might be helpful to do post-it notes, because actually you can move things to different boxes and go, that's not really an idea, that's more of a driver, or that's actually not a driver, that's actually an idea. And it's a really good engagement tool to do with your stakeholders, a bit like doing the process map is. This is a way of having people around the table to say, let's have a go at plotting out the plan on the page. And I mentioned the places that you can get your change ideas from. Include your process maps, include your data, include your colleagues, include looking at best practice through the audit, etc. So do think of the driver diagram as being a tool that really helps you plan your improvement. And then really almost the final stage is about how you go about testing those changes. So if you've got some ideas, what are you going to test? And we use what's called a PDSA cycle, which stands for Plan, Do, Study, Act. So you'll remember there was those 3 questions that looked like the lampshade, and at the bottom there was the circle, and it looked like the sort of base of the lamp, and this is that. So we've done the, what are we aiming to do through our SMART aim? How will we know through our measurement and data? What changes are going to be things that will get us there through our driver diagram and our process mapping and other things? How are we going to go and check whether these things are doing anything? So 4 phases: plan, which is what happens if we try something; do, let's go and try it; study, did it work; and act, what's next. And you keep going through that cycle for learning and improvement, essentially. So just in a bit more detail, here's what each of the quadrants are. So you need to have some objectives and to make sure that your PDSA cycles will actually answer what you're trying to do. So, for example, you might be saying, we're going to test out changing the referral process to make it electronic. So our objective is to implement some electronic referral process rather than a paper one. And if we do that, we predict that we might get an increase in the number of referrals rather than the bits of paper getting lost in the post. So we would plan to roll that out in a small area, for example, one small part of our service. We would then have a look at whether that had actually made a difference through charting the number of referrals that had happened at the beginning, and then over time we would study any issues and check back against our predictions, and then we would make some changes. And this is really built on starting small rather than going wholesale out and making changes, to say, are these really the right changes that will make a difference? Do we want to prioritise them, and then how do we roll them out? So this is about starting small and testing change in one area, one person or one clinic at a time potentially. Now that might be quite difficult, because how do you get one person to start doing something different and keep everyone else doing the same thing? So you need to work out at what level that makes sense to do that. Just to flag then, really what we're saying here is predict what will occur, document the problems and observations using your data, compare back, and if it matches your predictions, then you need to make some choices about whether you adopt that new change, whether you adapt it or you discard it. And essentially that's all the PDSA is doing, saying, are those changes the right things to get us to the point? So the cardiac rehab referrals, have they gone up? Is that intervention a good thing to have done? And as I mentioned, that's about doing small tests of change over time, and you can have multiple PDSA cycles going. So key kind of message coming out of this really is think ahead and start small. Pick off something, even if you've got a smart aim that's really big, pick something small to get going with. Process map and look at what's going on and pick a small area, and then really just get started, because you could spend quite a while sort of worrying about how to get on, and likely you won't always have included the right people at the beginning or get all the data. But as long as you approach it in a spirit of learning and improvement, that will make sure that you're always constantly thinking, how can we get better and do things differently? And whatever your job, whether you are a manager, a clinician, whether you work in audit, whether you're in clinical practice, whichever part of the ecosystem of this you work in, there's always something we can do to make a difference, whether that's helping to provide better data, whether that's helping to provide the resources for it, whether it's generating the ideas, whether it's leading change, whatever it is. And some tips here, and I've got a few different slides about tips, but this one is about find the willing. So there'll always be a few people who are really up for doing something different, or fed up enough that they're ready to make a change. Go find them and find where the energy is, because it's hard work working with people that don't have the time and can't do it. There will always be at least one person who's up for doing something different. Try and work in teams, because it can get really lonely working on your own on this stuff. And if you've got some expert knowledge and you're not the one who's going to be delivering the change, make sure you're using your knowledge to help support others. You can do that through helping make the case for change. It might be some of the data you're collecting through the audits, might end up in the business cases, etc. But just think about what's your role here to help make change happen if you're not directly delivering it. Don't worry about failure. We class that as learning, really. Just keep trying, because you won't get there until you try some things. And make sure that you celebrate success when you've done something that's worked well. Highlight that. It's really motivational for teams. And just really remember why you're doing this. Ultimately, we're trying to improve care for our patients, and thinking about those as if they were our family member. Would I want my family member to have that care, that experience, that outcome, that access? And if not, what can I do differently to help that? So hopefully, if you've come up with this problem, such as having looked at your audit data and seeing that you're a bit of an outlier in an area, and asking yourself the question, how do we improve ... that we've given you some tools that might help around setting a smart aim, thinking about what you're going to measure and using some visual measurement aids for that and looking at change over time, thinking about how you put a plan on a page and gather ideas and map the issues and think about what might lead to that, and then going through a bit of a cycle to enact the change. Now, I've obviously made it pretty simple, but in many ways, if you break it down to these steps, then it can be more simple and structured than the complexity that sort of sits out there. And I've mentioned this sort of process here. There are lots of other tools that you can use, and I'll show you a few resources in a moment as to where you might go. But essentially, if you use some of these steps, I think they'll really help you drill down when you've got a big problem and an issue into what might be the things that we can do to make the change. So next steps, think about what you want to improve. Really spend some time defining your question. We've got a note here saying engineers take a long time over this. People who are developing solutions think about the question and the aim being really, really important. Don't rush that through. Often people just sort of copy paste a high level statement and then carry on. But what are we here to do? Really spend time composing your team and think about how you're involving patients and staff, and start thinking about what do you want to measure, what techniques have resonated here. Did you like the driver diagram? Were you a fan of the process mapping? Where might you start? And make sure you use data because it will help you understand what you need to do and where you might change. So I've stolen this next slide. It's been from some colleagues who pulled together some links and resources. In fact, one of those might have already presented to you. So hopefully, if it's repetitive, it's a good reinforcement of some places to go and look. And I've put my contact details up here. As I mentioned, we at UCL Partners are big advocates of using lots of data sources, including National Clinical Audit, to help drive improvements in patient care. And so I'm really happy to be contacted if you want more signposting to some of our education and training resources, or anything here has particularly resonated. But I will hopefully be back a bit later today to answer some questions for you.